Great. Thank you so much. I'd like to thank the organizing committee for a great conference and for the invitation. So for the next 20 minutes, we'll focus more on transcatheter valve therapy and if there's any difference between men and women. So most of the talk will be tailored towards TAVI because we have more data with TAVI and a little bit on mitral transcatheter edge-to-edge repair. So in order to understand the outcome differences between men and women who undergo TAVI, we need to understand what is the baseline characteristics because it would be driving some of those outcomes. So when we look at women undergoing TAVI, they usually have smaller BSA, they have small aortic annuli, which actually could be a risk for having more patient prosthesis mismatch. They tend to be older, but they also have less comorbidities, including a peripheral artery disease, but they have smaller femoral arteries. They tend to have higher STS only in one of these trials, which was the SIR-TAVI. So what is the mortality difference between men and women? So let's kind of go back to the landmark trials and look at the cohort of core valve, this is the high-risk core valve cohort. So if you look at the whole cohort, you can definitely see that surgical valve compared to TAVI was a bit lower in terms of mortality. This is for the whole cohort. If you extrapolate only women from that cohort, you can see that the difference becomes more pronounced. And it's not necessarily because of the drop in the TAVR mortality, but it's also because of the SAVR mortality is actually higher than men in this population. This was also replicated in the balloon expandable valves in the partner trial. And as you can see on the top diagram is the women difference in terms of TAVR versus SAVR. SAVR is in blue and TAVR is in red. And you can see the two graphs really diverge between women compared to men. So they really benefit from having TAVR compared to SAVR in high-risk population. When we look at the Italian Observant Registry, we also find a kind of a similar trend that women who have higher mortality in the SAVR arm compared to men, and women, when it comes to TAVI, they have actually comparable mortality compared to men. So when we just focus on the TAVI arm only, is there really a difference between men and women? From the high-risk TAVI, which was the core valve trial, there's really no difference, and so is the intermediate risk. So women and men do about the same in terms of peri-procedural and 30-day mortality. This data comes from Frailty AVR, which was an older population undergoing TAVI, and as you can see, the survival in terms of up to 1 year in this case was pretty similar between men and women. However, they also looked really extensively into the subcategories, and one of them was having pulmonary hypertension, PA systolic pressure more than 60. And as you can see, majority of the groups are similar in terms of men and women if they did not have pulmonary hypertension. However, when women develop pulmonary hypertension, they actually do the worst in terms of survival. So there's a bit more data in terms of TAVI mortality in women versus men. This is the biggest meta-analysis that looked at this. It included 23,000 patients, women who undergo TAVI, and they found that the mortality, 30-day mortality, was pretty similar between men and women, which is about 6%. Of course, a valvular outcome in women versus men talk would not be complete without mentioning the WIN-TAVI, which Professor Schief was part of. And this actually just looked at registry enrolling all women undergoing TAVI. There's really no comparison in this particular publication, but it tells you that there are comparables. So if you look at the 30-day mortality and death, there's about 4.9%, which is comparable to what we've seen in previous trials. And the 1-year mortality, the composite outcome is about 16.5%. But they also looked at something interesting, is whether the pregnancy, having had a pregnancy in the past or not, if there was a difference. So in red is people who have not been pregnant, and in blue in those who have been pregnant. So there is a numerically higher events in those who have not been pregnant, but that did not translate into statistical significant difference. So there's really no significant difference between women who've had a pregnancy in the past in terms of their outcomes. So what about stroke? Stroke is one of those that it's not concurrent in all the trials. So the partner trial did mention that there's actually higher stroke in women undergoing TAVI compared to SAVR when they compared it to the men group. But in the SIR-TAVI self-expandable valve, it was actually about similar in women versus men, so as in the Observant Italian Registry. Something that keeps coming back is the vascular complications and bleeding requiring transfusion, which has been shown in the Italian registry that it's actually more common in women than men. This has also been replicated in the meta-analysis, which also shows that usually women develop more bleeding complications and vascular complications compared to men. The frailty AVR also commented on this, and there was a significant difference in terms of major vascular, and so as discharge to rehab in this population. But the majority of stroke and acute kidney injury was pretty much comparable between men and women. When they, in terms of the frailty AVR, they looked deeply into those who've had valve size greater than 29 or less than 29, and they actually found that in red is women in general, and in dark red is people who have TAVI greater than 29, and blue is in men. So you can actually see the major incidence goes up, and this is mostly 1 month mortality and morbidity according to VARC2, and it goes up in those women who have greater than 29 millimeter. What about paravalvular? Women might be lucky in this. They actually, the data with the 2 years shows that mild PVL is actually worse in men than women, and there's actually some data to hint that maybe mild PVL is actually not that benign as we think. The meta-analysis also pointed out that women have less of the moderate and severe AI as compared to men, and those both were statistically significant. We're also lucky when it comes to heart block and pacemaker. It seems like from the observant registry, the Italian registry, if you look down this side, that you can see that pacemaker and AV block was about 17% in the male population and 9.6% in the female population. And this was also replicated in the meta-analysis that women usually have less pacemaker placement compared to men. What about valve function and patient prosthesis mismatch? We know that patient prosthesis mismatch is more of an issue with the small aortic annuli, especially if they undergo SAVR. So this comes from the SIR-TAVI group, the core valve. So you can see that TAVI versus SAVR in females and TAVI versus SAVR in males. I don't know if the pointer is working or not. So in the first 2 columns, you can see that that's the women group, and the last 2 columns are for males. And in the SAVR arm, I just want you to look at the second column. You can see there's actually a great numbers of both moderate and severe patient prosthesis mismatch in the surgical arm for women. And this has been translated into higher mortality in other publications. So moving on to mitral transcatheter edge-to-edge repair, we have less of data with that, but this comes from the COAPT trial, which it's a functional MR data that led randomized controlled trials, but they also had another publication that looked at sex-specific outcomes of mitral tear. And what they found is actually kind of similar to what we saw in TAVI, is that women usually have less comorbidities, but they have worse functional capacity according to their mitral group. But what's interesting is that if you look at the diagrams on the diagram on your right-hand side, so in red is men, so that dashed line is with the transcatheter valve repair, and if you just focus on red, you can see how men do really bad with just medical therapy, but then the moment they get the transcatheter edge-to-edge repair, their cumulative hospitalization for heart failure significantly drops. However, when you look at blue, that's women who have had medical therapy only, and if you give them a transcatheter edge-to-edge repair, it does come down, but not with the same magnitude that we see with men. So in terms of other publications, this was a meta-analysis that looked at mitral transcatheter edge-to-edge repair, included about 24,000 patients, 45% of those were women, and they also found that those patients are usually older but had less comorbidities, but their procedural outcomes were comparable in terms of procedural success and mortality, and their hospital outcomes, again, replicated what we saw with TAVI, that they've had higher periprocedural bleeding. And there was also a hint of towards higher stroke. The long-term mortality, when it was adjusted, it was actually better in women after a year. And this was also seen in one of the few trials in the TAVI registries as well. And this could be kind of explained by the less comorbidities in the women arm that gives them this advantage over a year. So with that, in summary, so we know that if we try to compare TAVI and SAVR mortality in high-risk and intermediate-risk patients, we know that women actually do better than men with the TAVI versus SAVR. Some of it is driven by higher mortality in the SAVR arm for women. We know that mitral and TAVI and mitral transcatheter edge-to-edge repair procedural mortality is really comparable between men and women. There is a questionable higher stroke that comes in some of the trials post-TAVI in women, and there is actually a hint towards higher stroke in mitral transcatheter edge-to-edge repair. Women have favorable outcomes when it comes to heart block and paravalvular leak, and there is a trend towards a lower, longer-term mortality after TAVI and transcatheter edge-to-edge repair, which again could be explained by the less comorbidities. However, despite all of this, we still have high bleeding risk and vascular complications, both in the TAVI and mitral transcatheter edge-to-edge repair. Unfortunately, the data is lacking when it comes to the Gulf region, so it would be nice to see if we have similar or different data. Thank you.